welcome back to another video lecture for first aid. Hopefully you've already watched the introduction video, which includes the survey of the scene, primary survey, secondary survey, because that's really the skeleton of the course right there. We think of the scope of a first aider. And then we just plug in all the information in the different scenarios and whether it belongs in a primary survey or a secondary survey, once we realize it is safe for us to enter the scene during that survey of the scene. And we understand and kind of recognize who we need to go to first. And then hopefully you've watched the video and have already done your plan of emergency for a facility. Maybe you haven't done that yet and you're working ahead in the written portion first, and that is fine. But be sure to go back and make sure you get that done, because when you start making that plan and start thinking about legal aspects of first aid, it's really important to realize that if we don't have a plan in place, that can make us more liable, especially if it's our facility, part of our job, part of our duty. And that's some of the things we're going to talk about today. And that comes to the realm of the legal aspects of helping someone. Whether it's part of your job or whether you're volunteering, there's always that possibility of being sued. And my question is, what can someone sue for today? In today's day and age, they can sue for anything. They can sue for just the way you talk to them. They can sue for something that happened, a tree limb fell out of your tree and onto their property and damaged something. They can try and sue for that, for those property damages. What I want to talk about is how do we protect ourselves, number one, and make sure that we don't get into, try to keep from getting into a lawsuit. Number two, talk a little bit about if we do get into a lawsuit, then what are we going to do? What's that process after that? But this course really doesn't focus on that. It focuses more on the volunteering portion as a first aider. When we think of legal suits, I like to think of it as a lottery. In today's day and age, to a lot of people, suing someone is like winning the lottery. If they can find something to sue for, they just make some fast money easy. So people are sue happy, and we're in a litigious society. There are lawyers everywhere for everything, and there are good things lawyers do. But then there's also things that are promoted that drives up cost of insurance and many other issues. So there's two sides of the table. As long as we keep that balanced, the attorneys have a very good place in helping us protect ourselves and protect those that we serve as a first aider or a volunteer, or if it's part of our job. First thing I'll think of is, what's it mean if you're liable? If someone's liable, someone says you're liable for that, all that means is that you're legally responsible. You think, okay, now how am I legally responsible for this? We'll talk about a few things and really look at it more from an aspect of something that you're doing or not doing as a first aider or providing care. When we think if someone's liable or legally responsible, one of the first things we look at, if you want to go back and pull up the PowerPoint, from the very first PowerPoint, it's been attached to 2 or 3 different things already. This information is in that PowerPoint, and it's annotated, so the definitions are there. So if you just want to watch this and listen, take some additional notes. So there's sometimes, many times, it'll help if you just hear it lectured versus just reading it. I know it does for me anyway. So if you have printed off that PowerPoint already, you can take this and just write anything that's not on there that may say that sparks your interest or thinks, hey, this is something I might want to remember. Exam-worthy information, definitely comes off of those notes. It's already annotated for you, as well as your text and this supplemental video. So negligence. Someone says you're negligent. What's that mean? What's it mean if somebody comes up to me and says, Gary, you're negligent? What you did was inappropriate. Or what you didn't do, you should have done. Either way, what they're saying if they think I'm negligent is that negligence is you did not act as a prudent person would act. You did not act as a prudent person would act. So then what we have to ask ourselves is, what is a prudent person? A prudent person is a person and their actions that has the same level of training. So if I'm prudent, I do what my training teaches me to do, or I do not do something that is not in my training. So I don't try to give a tracheotomy to someone. I'm not trained in it as a first aider. I'm not even trained in it as an athletic trainer. in which I practice. So when we think about first aid, we have to stay within our scope of practice, which we'll talk about in just a few minutes. So negligence, 3 things have to be shown that you did not act as a prudent person would. The first one is you have a duty to act. So it's part of your job. You're supposed to do this, to be negligent. There's some other types of negligence, but typically we'll attribute to these things. You had a duty. The second thing is you breached the duty. You did not do something you were supposed to do, or you did something you wasn't supposed to do, whether it's just a basic mistake or something outside of your scope of practice as a first aider or your training, beyond your training, then you've done something you shouldn't have done. And we have some other terms for those we don't get to in this course. It's a misfeasance if you just make a mistake and you're allowed to do it. It's a malfeasance if you did something and it's outside your scope of practice, beyond your training. Then the third thing, harm was done. So if harm is done, that doesn't matter whether it's physical or mental. You've heard of people suing for mental anguish and suffering. So pain and suffering. So there's a lot of different things when you think of, is it your duty to act? Did you breach that duty? And number 3, was harm done? So if all 3 of these things are shown, you might be able to be deemed as negligent. So as we go on and look at other things, when we think of negligence, we've already mentioned a little bit an act of omission. I omitted something I should have done. I should have put a barrier or something on that wound before I added direct pressure. So when I took my hand off, it just started bleeding again. There's nothing there to wrap on and keep that compression on. So there's a lot of different things when you think of an act of omission. I left something out that I should have done. If I'm doing CPR and I skip checking the pulse, or I skipped the compressions, which would be the biggest part of CPR, then you missed something, you left something out. The next one we'll look at and consider is the act of commission. You committed something you did. Whether it's something you're allowed to do, you just made a mistake, or whether it's something that's outside or beyond your training, outside of your scope of practice, it's an act of commission. You committed it. So when we think about being that prudent person, if we are prudent, we're going to not leave out anything we're not supposed to leave out. We're going to do the things we're supposed to do, and we're not going to do the things that's outside of our training. We're not going to make mistakes. Yes, mistakes happen, but is it something that was detrimental to harm? Did it cause harm? So yeah, maybe my duty, I may have breached the duty by making a mistake, but there was no harm done. If there's no harm, then it's probably not going to go anywhere. You never say never and never say always in anything, because as soon as you do, the next person that walks through the door will prove you wrong. We've mentioned several times scope of practice. Scope of practice is just your level of training, and then what a state or a credential, meaning a first aid card, CPR card. Me as an athletic trainer, I have a national credential. What that credential allows me to do, it states that this is within the practice of first aid. This is within the practice of being a medical doctor, is what a medical doctor can do. This is within the practice of being a nurse. A nurse cannot do a doctor's practice. There are some things that overlap. Both can take a blood pressure. I can take a blood pressure as an athletic trainer. An exercise physiologist can take a blood pressure. So blood pressure, taking a blood pressure is one of those things that overlaps multiple different practices, but at the same time, we have to know what we can and cannot do. And there are some things that we don't do because it's beyond first aid, it's beyond the training. Because remember the definition of first aid: immediate and what? Temporary care until a more qualified person or equally qualified person takes over. That's our first aid. That's our definition. We're staying in. We're not going to go beyond that. So we stay within that scope. So when we think about all this in a situation, if something does happen and we're volunteering, let's say we're just volunteering. I'm walking down the street or driving somewhere and there's a car wreck and I stop to help. Or I'm walking down the street, something happens, somebody falls and gets injured and scrapes their knee up, and I stop to help and offer help as a first aider. Then I'm protected by the Good Samaritan law. In the assignments, you'll have a link to a page, and you can look at the Good Samaritan law in the state in which you live. I would strongly encourage you to do that, So you understand the Good Samaritan law and what it states. They're very similar, but there are some subtle differences from state to state in what states do. The next thing I'll look at, the last thing on this, is documentation of actions. When something happens and you provide first aid, you probably, especially if you don't know the people or it was a car wreck or something, you want to document what happened. You want to document where it was. If it was outside, what the weather was like. Was it cloudy? Was it raining? Was the visibility low? Document that information. Document who else was there. Find out their names and at least a phone number. Even if they move, that phone number can go back and trace who had that phone number in the past. But get their names. Find out who, report who did what. Write it down. I always had a college professor said use the WID approach. W-I-D. Write it down so you don't forget. Because yes, you could be summoned to court because you stopped and just maybe you're the one that called 911. And whenever it didn't offer any assistance because other people were doing things, but you saw everything. Still document. Document what you did, that you called 911, or that you provided this first aid, whatever the first aid was that you did. And keep a copy of that. I would recommend if it's an accident somewhere that there's a report written on, that you give a copy of it to the officer to put with that report with your contact information so you can be available to them to assist if you needed to. So when we think of legal aspects, yes, there is a liability. There is a certain level of liability you're legally responsible for. Number one, you have to be acting as a prudent person would act. You have to be within your scope of practice, practice within your training. We have to do or not do the things we know that are in our level of training. And we have to remember what protects us and document. I'll say document 2 or 3 times, but it's very important to document things. So when you think about the legal considerations in first aid, yes, it is minimal, but it is there. And luckily, most people, out of moral obligation or at least feel like I need to help with something of what I can, then definitely help. Help out with what you can help out with. And go back to that primary and secondary survey. Help with the areas you are comfortable working with and helping with. If you don't like blood, stay away from that, and you be the one that calls 911, maybe stopping traffic, keeping it from, if it's along a road or on a road, helping with traffic control. So in your worksheet, you will have several of these to fill out and to define. You can use this video, the things that I've said to define them. You can use what the book says to define them. Look them up, but please, one of the things to make sure is make sure it pertains to this class. Because as you know, when you look up a definition, there's multiple definitions of things. So make sure you keep it to pertaining to this, to the content of this course. The next thing we'll look at and start to get into is kind of our starting point. Let me back it up here one. There we go. Our starting point of directional terms. When we go to help someone, and again, this is in your PowerPoint also, so if you can't read all of it from where I have the camera set up, don't worry about it. It's not a real big deal. I just wanted you to be able to hear me say some of it, because some people even do better just with the voice and seeing someone and hearing the voice fluctuations. It does help with retention. So when we think about providing medical care, everything in medicine with respect to a human being is described from one position. We call it anatomical position. And this is me standing in anatomical position. Anatomical position is standing erect, straight up, looking forward, arms slightly abducted or out to the side, palms facing forward, feet slightly apart, think shoulder width apart, standing facing forward. Everything is described from that. So when we describe some terminology in a second, everything on the front side is anterior, everything on the back side is posterior. Toward the head, superior, toward the feet, inferior, and we'll get to those in the next slide. So everything is described from this position. This is a very important position to think of, because if we're not describing it from the same starting point, then we're not even starting at the same place. Someone may say up when I call it down. Someone may say toward the middle when I'm thinking toward the outside, because we're not describing it from the same way. So in medicine, everything is described this way. So when you go on to another class, whether in anatomy, any athletic training classes, exercise science classes, biomechanics classes, any classes that deal with the human body, this is the starting point. Some will break it down from 5, we'll actually break it down into 7. Talk about the head being square on the shoulders, and some other things. But this is enough that if you're standing straight, looking forward, standing straight up, that kind of combine a few into one, so you don't have to remember as many. So 5 things. Standing erect, facing forward, arms slightly abducted, palms supinated or facing forward, legs slightly abducted or apart. Think of your feet shoulder width apart. Those are the 5 things you need to remember when you're thinking of anatomical position. And the reason that's important is when we get to this terminology. So I put a picture there of someone in anatomical position. It's kind of a sketch drawing. Of course, the previous picture of me is a little sketchy, but that's beside the point. We want to think of a couple things. One is mid-sagittal. Mid-sagittal, if you're looking at the PowerPoint you've already printed out, has all the annotation, is a line that divides the body in the right and left halves. So a mid-sagittal line starts at the forehead, splits down between the eyes, down the nose, splits the mouth in half, straight down the sternum, through the navel, the belly button, and straight down between the legs. Divides the body into perfect right and left halves, or near perfect. So when we think mid-sagittal line, that's the middle. The mid-sagittal line, dividing your right and left half, that's the middle line that we're going to describe from. Another one we'll mention is I don't have here, which I do have on the one you've printed, is one called transverse. A transverse line divides the body. It's a horizontal line in the upper and lower portions, or part of the body. So a transverse line that we're going to talk about divides, think through the navel, horizontal to the floor, is a line that divides into upper and lower portions. So then we can describe from there whether something is up, inferior, up, down, inferior, or up superior and down inferior. The first one we'll look at is anterior versus posterior. I already mentioned that. So if I'm standing, let me turn my anatomical position sideways. Anterior is toward the front of the body, this way. Posterior is toward the back of the body. It's a descriptive term. Something is anterior to. So if you wanted to say that, my palm is anterior to the back of my hand. Posterior toward the back. The next one we'll look at is medial and lateral. So if you think of that midline, dividing the body into perfect right and left halves, between the eyes, through the nose, down through the mouth, splitting the chin, down through the sternum, all the way down through the belly button, straight down to the floor. If I go from that line, lateral is away from that line. Either direction away from that line. So it's right lateral, left lateral. And it's my right and left. It's the patient's right and left. So if you're the first aider and I'm the patient, my right side, my left side. So my left lateral, my right lateral. Don't get confused, because if you reach out with your right hand, you're reaching to my left side. So don't get confused with that when you start to write things down and document it. So lateral is away from the midline. Medial is moving toward the midline. So if I want to say, if I want to use that, I would say my sternum is medial to my shoulder. Or I could say my hip, right here on my side, is lateral to my belly button, my navel. Next term we'll use distal and proximal. Almost universally, distal and proximal is used with the extremities, the arms and legs. Distal is the point furthest from attachment. So we think where the arm attaches to the body, because our body is our axial skeleton. Our our abdomen, our chest, head and neck is axial skeleton. Our appendicular, appendages, I'll get it out in a second. Our appendages are arms and legs. We call those extremities. So my fingers, my fingertips, my fingernails are almost the most distal part of my extremities. If ladies or those who have long fingernails, you may have the most distal part is the tip of your fingernail. The most proximal is where it attaches. So if I want to say my shoulder is what to my elbow, my shoulder is proximal to my elbow. My wrist is distal to my elbow. So the directional terms, they're a reference to something that you're pointing to. Superficial and deep. Superficial is toward the surface. My skin is superficial. My heart is deep, and there's a good reason. It's protected by the ribs. We're designed great. The way we're made is that our body, some of the most critical things are protected. Arteries are deep. The things you see on the surface, your veins are more superficial. Your arteries are deep, and for very good reason. The arteries are high pressure. The veins are much lower pressure. Therefore, if you get cut, which would you rather cut, the high pressure or low pressure? And that's an obvious thing. You don't want to cut it all. But if you do get cut, the low pressure, low bleeding rate, you can get it stopped generally. It's when you get an arterial bleed that you really have a problem because of the high pressure. So superficial toward the surface, deep internal. Again, directional terms with respect or with reference to something. An important one, I'll use these words a lot throughout the course. Supine and prone. Supine is just face up. So you're lying on the floor on your back, face up. Prone is you're lying on the floor on your stomach, or on the bed or something, on your stomach, face down. So lying supine, lying prone. Face up, supine, face down, prone. Go back and practice some of these, read the definition and think, okay, if I put myself in a supine position, how am I at? I'm lying down on my back. If I put myself in a prone position, I'm lying down on my stomach, face down. Practice them, kind of get to know them, because the terms will be used if I do it some of the other video lectures or within the other assignments, the terms will be used as general knowledge. Something I want to talk about is recovery position. Recovery position, if you look in your book or look up a picture of it, it's a position to put someone in that's ill, not feeling well. Maybe they had a seizure and they woke up and they're lying there and they're just tired and they need to rest. Then we can put them in this recovery position. And what recovery position is a position that the person's lying on their side. When they're lying on their side, they take the back of one hand, doesn't matter which it is. I'll say if I'm lying on my left side, we'll do it lying on the left side. You can do either side. If I'm lying on my left side, you take the back of your right hand, the posterior part of your right hand, put under your left cheek. As you can see, what this is doing is going to put my elbow out like this. It'll keep me from rolling onto my stomach when I'm lying on my side. So take the back of your right hand, put behind your right cheek while you're lying down on your left side. And then take the top of your right foot and put behind your left calf. That's going to cause you to bend your knee, and your knee, and the knee that is bent, that is the knee that's on top, the right knee, will actually lay down against the table, kind of like your elbow does, just like this. It be your knee laying like that also. And it will keep you from rolling onto your stomach. But gravity, since you're laying, gravity, if you go to sleep, will keep you down on your elbows, will keep you from rolling over on your back. So it's a good position to put somebody in. If they do start getting sick, they're not going to choke on it. We can still check vitals during the position. We can talk to them and do things we need to do to be able to help them. So the recovery position is lying on a side. If I'm lying on my left side, the posterior part of my right hand against my cheek, left cheek, and the top of my right foot behind, push it against the left calf, up against it. And that will allow you, what I will probably do is, I'm going to go back and add a picture. Since I don't have it here, I'll do a picture of this recovery position. It's in your book. but they have it laying on the right side. So you take the back of your left hand, put under the right cheek. So it's just the opposite. So you can't see your picture of it in your text. Next, we're going to talk about shock recovery. Shock recovery is if we get someone in as a bleeding, or they go into shock from whatever they're going into shock over, is a position we want them in. We want them lying supine. Remember, what is supine? Okay, supine is, yes, lying on your back, face up. And then we want to elevate their feet 12 inches. About 12 inches. Put something under their feet. And if they're cold, we want to cover them with a blanket, a coat, something over top of them if they're feeling cold. And this is the position of shock recovery. What it's doing, you elevate the feet, it's helping return the blood back to where it needs to go internally, where it's most important. And kind of keeping as much blood from going up to the feet and legs. We really don't need the blood there. We need it internally to conserve heat and to make sure we don't get too much blood in the legs and end up not getting it back to the heart, causing our blood pressure to drop. So it's one way of helping maintain our normal blood pressure and keeping blood to the most important areas. The third one is recovery position. Or I should say not recovery position, raised head and shoulders. I had the wrong one in my mind. Raised head and shoulders. The raised head and shoulders, typically someone trouble breathing. Another term for it may be long seated. So it's basically think of someone sitting on the floor against a wall. So if I'm sitting on the floor against a wall, then I can, I'm raised up, I can breathe better. You know, if someone's really tired, they're bent over like this, what the first thing we tell them to do in athletics, stand up straight and do this and walk around. It expands the chest cavity, helps you recover quicker. So if someone's having difficulty breathing, it's time to sit up against a wall. And their feet straight out in front of them. So it's long seated, legs straight, think long legs straight out. And seated, so they're sitting up, and you're able to take vitals, you're able to talk to them, and they're sitting on the floor. I wouldn't sit them in a chair and then prop their feet up on another chair, because if they start getting dizzy, they could fall out onto the floor. So go through these. When you read through the text on the chapters with this in it, be sure to pay attention to the pictures they have. They have some pretty good pictures in describing this information as well, and be able to use it and be able to identify it on tests. So if I say something is medial to your right hip, you know you're moving in. Or if I say lateral and inferior, which I don't have on here, is inferior and superior, which I'll talk about that in just a second. I just noticed I didn't put it on here. If I say if it's lateral to the right and inferior is down, then again you get to the right place. So one to add to this, which is and should be in your PowerPoint and on your list to define, is inferior and superior. Inferior is generally only with the axial skeleton, so it's your abdomen, chest, head, neck is inferior and superior. Inferior is moving down toward the feet, down toward the ground, moving toward the feet. Superior, moving toward the head. So above and below. Think of it that way. Okay, moving from there, what we want to start getting into, since we've talked about a lot of terminology. We've talked about an emergency action plan. We've talked about what to do when you get to an emergency, the scene, surveying the scene, the primary survey, the secondary survey. Now what I want to do is go over some things of norms. What are norms? When you think of vitals, what's the first thing that comes to mind? And obviously, if you look at the picture up in the right-hand corner of this, if you can see, it's a heart with the EKG script on there, and you can see that you think, okay, we want a pulse, yes. And we see somebody down here taking blood pressure. Blood pressure, yes, that's a vital. What else is vital to life? So blood pressure, pulse, breathing, and temperature. Those are the four we generally think as vitals. So if you look at the four in this box, those are the four I'd list as a vital. I will talk about skin color and pupils also, because we can get a lot of information from those. So we'll just spend a couple minutes on this slide. When we think about blood pressure, BP. what is good blood pressure? Do you remember when the last time your blood pressure was taken? What was it? A lot of times we go right to the idea of 120/80. And that's kind of what people have considered an average blood pressure. What I want you to think about for this course is a range. If somebody's in this range in the realm of first aid and providing them first aid and emergency care, okay, we're okay with it. If they're outside this range, can we explain it? Is there a reason they're outside of this range? And the first thing when we look at blood pressure, that 120/80 now is that borderline pre-diabetes. If you're below that for healthy living, that's great. If you're below 120/80, that's the idea, that's the goal, is be below 120/80. But what we want to think about for in here is the range. And when we think about a range, we think about 100 to 140 over 60 to 90. So 100 to 140 over 60 to 90. But the question is, what is 100 to 140? What is 60 to 90? I want you to start kind of getting into that. You used to think, well, why? Well, why? Ask why. Because standard of practice changes based on why. Why are we doing what we're doing? If there's not a reason for it, then why are we doing it? Again, why? So if we think about it, systolic over diastolic is what this is. Systolic over diastolic. Okay, that tells me a lot. What is systolic and what is diastolic? Systolic is a pressure that's exerted when the heart contracts. So when this heart muscle contracts, squeezes down, that's the pressure that is pushed. That's systolic. When it relaxes and is refilling, that's the pressure. When we think about the pressure, what we're looking at is the pressure that the blood is pushing up against the artery walls. Now, how much pressure is the blood pushing against the artery walls? So when the heart contracts and pushes down real hard, it's increasing the pressure. It's pumping up the pressure here to push the blood down through the arteries. Yes, the blood is moving through the arteries, but it's also pushing pressure against the artery wall. Have you ever had a water hose that was lying, especially some of it would go flat when you have this, when you turn off the spigot? When you turn the spigot on, what's the first thing that happens? That starts going through, but then also it balloons up. It gets bigger. So it's the blood going through the arteries, but the blood pressure, when we measure it, when we put this blood pressure cuff on someone and measure it, what we're measuring is the pressure pushing up and outward against the artery walls. So when the heart contracts, it's the amount of pressure during contraction against the walls. When it relaxes and is refilling, then it's still, there's a pressure against those walls. What's that pressure when it's refilling? So if we're in these numbers, we're okay with it. We measure it in mmHg, millimeters of mercury. That's a pressure reading. So we measure it in millimeters of mercury. 100 to 140 over 60 to 90. That's the range we want to be in. If we're in that range, we're happy. We're good with it. The second thing is pulse. And again, think of a range. Have you ever taken your pulse before? Most people will come right here to the carotid artery to take their pulse. Some people will come to the radial artery right here to take their pulse. So you find, if you bend your wrist, you'll see this cord stick up, and that's a tendon. Go lateral, again, think of your anatomical position. Go lateral to that cord, just down at the wrist, and you'll feel your radial pulse. For the carotid pulse, go right here, just off the angle of the mandible, of your jawbone, and press down, and you'll feel your pulse. Never squeeze like this to take your pulse. The reason is you have baroreceptors, they're pressure sensors in your carotid arteries. At the detect blood pressure. Great place for it because carotid arteries take blood up the brain. Brain is neurologic system solely dependent on oxygen. It needs that blood. It needs to know what the blood pressure is. It's how it controls it. One way to increase blood pressure is make the vessels, if you see this here, that's smooth muscle. The vessels can bear down. And when they bear down and constrict, then that's when the blood pressure can increase. Also, what it can do is increase the pulse, make the heart beat faster, and that will increase blood pressure. So if you push on both sides, it'll give a false reading of a high pressure is what it'll show, and your brain will bottom out your pulse, and you'll get dizzy and pass out. So you don't want to do both sides. I'd say typically, if you want carotid pulse, use your ring finger, or your middle finger and your ring finger, and then take it. So if somebody is on my left side, they should stay on the left side of my neck when taking my pulse. Don't reach across because you may drop your thumb. You can feel your pulse in your own thumb. Sometimes you can feel it in your index finger. That's why I think one of the best professions in learning to take a pulse is nursing. They do well in using, if you ever watch a nurse, almost all nurses I've ever watched take a pulse, is middle finger, ring finger. Physicians are pretty much that way too, but I think the nurses are among the best in training that way. So pulse, what is the normal range of a pulse? And the range we want to look at is 60 to 100 per minute. 60 to 100 beats per minute. Now the average is probably around 70, the average person. But if we're between 60 and 100 in the realm of first aid, then we're pretty much okay with it. It's one that we're not going to get too bent out of shape over. Unless they're always at 100, then there's a reason, then we want to watch that. And that goes back to healthy living. But again, remember, we're doing first aid. If it is a high pulse, we can always ask, does your pulse normally run high? If not, then we need to keep that in mind. When we take the pulse, whether it's carotid, right here, brachial pulse, right here. The thing about the brachial pulse, the brachial artery, which runs in the arm, is also a digital pressure point. If we're bleeding down here, we can squeeze on that digital pressure point, kind of the old idea of a tourniquet, but just squeeze down on it with one hand while applying direct pressure with the other to control distal bleeding. But on an infant in CPR, you'll use the brachial pulse. On an adult, sometimes it can be a little more difficult to find. And then also the radial pulse, right here. The other thing to think about is in the lower extremity, the femoral pulse. So if you look in your book, a picture of it, the femoral pulse is on the inside of the thigh. And you can also think of it as the digital pressure point, digits being the finger, pressure point for the lower extremity. To put pressure on it to slow blood flow down to the lower extremity. And then there's some other pulses. The distal pulse for the upper extremity, we call it distal, meaning further away, is radial. Distal pulse for the lower extremity, if you look at your foot, right behind your on the inside of your foot, the middle of your foot, so you think toward the midline, your ankle bone, your malleolus, behind it is what we call a posterior tibialis pulse. We usually say posterior tib. You can also find one on top of the foot, we call dorsalis pedis. So we take these pulses, that's a distal pulse. The other thing you can do when you think about pulse, or think about blood flow, especially to distal part of the body, is push on the fingernail. So if you take your fingernail and just push on it, it'll go blanch, turn kind of white. Let go, and does the blood flow come back in? You can also do it to skin. Just push on it and let go. See, does it turn blanch and the blood flow come back in? We call that capillary refill. So if somebody has nail polish on and you can't do it, that's fine. Just push on the skin. Does it turn blanch, kind of white? And does the blood flow come back into it? So when we think about pulse, 60 to 100 per minute. So you need to take it for an amount of time and count the beats, the bump, bump, bump. You hear that thump. You feel the thump, not hear it. You hear the thump against your fingers. So you feel a thump, 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 thump. That's my pulse right now. I can feel it. So you count that. Generally, probably the most common is for 15 seconds. So if you take it for 15 seconds, and let's say it is 13, or let's say let's give a little bit bigger number. That would be somebody that's in really good shape or they're below the range that we want them at. Let's say it's 23. So 23, if we take it for 15 seconds, that means we have to multiply by 4 to get our number. And in our head, sometimes in an emergency situation, that may be difficult to do. So the easiest way to do it is take that 23 and double it, 46. Double that again, and what's that? 92. So whatever number you get, double it, and double it again. So double it twice. So double the number you get, when you get that answer, double that answer. And that will give you the pulse. Third thing is respirations. How many times do I breathe in a minute? How many breaths do I take? 1, in and out. 2, in and out. So with respirations, we usually breathe about 12 to 20 times per minute. 12 to 20 times per minute. That magical average of about 16. So if we breathe about 12 to 20 times a minute, again, we have to count it and then double it and double it again if you do it for 15 seconds. If that's too much, sometimes just do it for 30 seconds. You can do 30 seconds for pulse, 30 seconds for respirations, and then double. All you got to do is double it one time for each one. The one time you don't want to take pulse for 30 seconds is when you're doing CPR. Remember, when you watch the things on CPR, go ahead and start getting ingrained in your head. We take the pulse. Once we are unresponsive, no longer than 10 seconds, try to find a pulse. Because what we're looking for when we're seeing if someone needs CPR, they're unresponsive, so they're unconscious. We check for pulse. If there is a pulse and it's faster than 60 times a minute, so 1001, 1002, 1003, so it's faster than 1 time each second, then, okay, we don't need to do compressions for them. We move on to the next thing, possibly breathing for them when you do rescue breathing. When we think of respiration and pulse here, we're taking it to get the pulse per minute, not thinking about CPR. So don't confuse the two and what you're doing. When you're doing CPR, all we're doing is looking for a pulse. Is it faster than 60 beats per minute? If it is, then that's sufficient. If it's not, then we consider it insufficient, or if it's very weak, we consider it insufficient. So blood pressure, pulse, respiration. The next one is temperature. And usually, I'm used to using Fahrenheit, so if you're used to Celsius, you would need to convert that to your Celsius. But it's 98.6 degrees Fahrenheit. 98.6. I think this is one of the few things that's actually recorded in Fahrenheit in hospitals, because most things they use the metric system for. Centimeters, millimeters, things like that are the way things are measured, not in inches or feet or anything. So temperature, pretty steady, about 98.6 degrees Fahrenheit. Some will argue the new average is about 99, but the really 0.4, I don't think the 0.4 at this temperature makes that much difference either way. Some people naturally run a little bit lower, some people naturally run a little bit higher, but we really don't give this a range. The next thing I want to talk about, let me erase this here real quick, is skin temperature or skin color. When we look at skin color, is it normal for the environment they're in? Something to consider. Get all this off here real quick. Okay. When we think about skin color, is it normal for the environment we're in? So if someone's skin color is really red and it's not in their ethnicity to have a red tint to their skin or any other color we want to talk about, then why? I mean, that could be a sunburn. That could be, if it's red, heat stroke. And we'll talk about many other things throughout this course that it could be. So what color is the skin? Is it blue, what we call cyanotic? C-Y-N, cyanotic, cyan, C-Y-A-N-O-T-I-C. You think about your Crayola colors. So skin color, is it bluish color? What's that mean? If it's red, what's that mean? Well, if it's yellow, they got yellow around their eyes, it could be jaundice, that can be a liver problem. Then we think about pupils. Pupils can tell us a lot. These aren't vitals. Skin color and pupils are not vitals, but we can gain a lot of information from this. When we think about pupils, what I want you to think about is this acronym. PERRLA. And what it is if we draw lines, it's like this. Are the pupils equal? Or are they the same size? Or is one bigger than the other? Are the pupils equal? Are they round? If not, then what is one shape and one another shape? Some people were born with unequal pupils. It's called anisocoria. No, it's something to know. Is you can always ask them, are your pupils normally a different size? You may go, no, why? Well, okay, that's one to check. One's a little bit bigger than the other, but it may or may not mean anything significant. Probably if they've been hit in the head or hit with something, may have a concussion, and one pupil is bigger than the other. That's being pressure being put on one of the cranial nerves. So yes, that is significant, but we don't want them to overreact to it and get really out of control because they're scared. So are the pupils equal? Are they round? Do they react to light? RL. Do they react to light? So if they react to light, is when it's bright out, the pupil should constrict. In darker light, the pupil should dilate. So if you're outside, you could have someone cover one eye. The other eye should constrict a little with, or should dilate a little with it. And then when you uncover it, you should see the pupil go from dilated to constricted. And if you're inside and have a pin light, you can take the pin light and shine it in one eye. When the light hits it, it should constrict. Notice the speed that it constricts, or that when it constricts or dilates. Notice how the speed from one to the other. Is it the same right to left? And then the other thing we'll look at is accommodation. Accommodation is whether you're focusing on something close or focusing on something far away. So if you take a pencil and turn it so the writing is toward me, and bring the pencil in very close, what do my pupils or my eyes do? They cross. We call that converge. And they constrict. So if you watch their pupils very closely, do this to someone. Get a pencil, have it close, have them take the pencil, start out here, go very slow, come in very close. Watch their pupils. They will converge and they will constrict. Control the amount of light coming in so they can focus and read. That's normal. When we look at something distant, they diverge. I would always do something close first and then take it back out and have them look over your shoulder at something, or just have them look over your shoulder at something out behind you, and do the pupils diverge, come back apart. And then also, do they dilate? So if you keep the C's and D's together, when it's close, they should constrict and converge. When it's focusing on something close, focusing on something far away, they should diverge and dilate. So something to think about when we're thinking about what's normal. And when we know what's normal, then when something's not normal, we can say, wait a minute, this isn't right. What other signs and symptoms? Remember, a sign is something you can see. A symptom is something you're told. What other signs and symptoms are there? As we're doing sample and a head-to-toe evaluation, what else are we finding out? You will not practice blood pressure in here, but you can do pulse, you can count respirations, and temperature, it can't be taken. But if it's your duty to act, then typically you're going to be trained in blood pressure. This class does not train you in taking blood pressure. And it does not train you in taking an actual temperature. First aid does not do that. But you could get something very easily to roll across someone's forehead, and even some things that'll scan the forehead. And there's some argument of how accurate it is, but there's a lot of correlation between that and internal temperature. A lot of ways to take temperature besides the thermometer under the armpit. You can do rectal temperature, but then you're getting into a more advanced outside the scope and training of first aid. So pay attention to vitals. What's going on with, especially with pulse. Pulse can tell us a lot. If pulse continually goes up, but they keep getting dizzier and they're feeling faint, they start getting bluish, they're getting cyanotic, but their pulse keeps shooting up, we know possibly they could be bleeding out. They got something going on internally. The next thing I want to look at are the abdominal pelvic quadrants. And what we want to do is think of what's normally there and possibly in a couple of injury things what it can present. So when you think of the abdominal pelvic quadrants, again, anatomical position. So it's the perspective of the person, the patient. It's their perspective. It's their right, it's their left. So when we think about this, the perspective of me, the patient, my right, my left. If it's my right and my left, let me stand on this side, which two quadrants are in my right side and which two quadrants are on my left side? If we have the mid-sagittal line dividing me into perfect right and left halves, and the transverse line dividing me into belly button in the upper and lower portions of my body. So then quadrants 1 and 3 would be my right side. Quadrants 2 and 4 would be my left side. So when we think about the quadrants, two ways to number them. It's like as if you are reading me like a book. Start on the top line, left to right, and you come down to the next line, left to right. 1, 2, 3, 4. The other thing you can do is say upper right, it's the patient's upper right. Lower right, the patient's lower right. Upper left, the patient's upper left. Lower left, the patient's lower left. So again, quadrant 1 is also